Dear friends, watch the main incision. The patient was not cooperative. I was moving, and the left edge of the main incision has gone a bit towards cornea, and this is not good. In such cases, we should hold the eyeball with a fixation forceps near the limbus very firmly and then make the incisions. This is a diabetic patient, and we can see that there are radial opaque lines, looks like cycle spokes. And I call these cataracts cycle spoke cataract. These cataracts in diabetic patients can be very troublesome, and though they appear soft, these diabetic cataracts are often hard to conquer. By this time, the capsulorhexis has been performed. Now I'm going to do hydrodissection. So far, no problem. I'm going well, but see what happens when I try to manage the nucleus. First, I thought of prolapsing one equator of the nucleus out of the bag, but it didn't happen. So I inject some viscoelastic substance and I go into the eye with the phaco handpiece. Going to use Oatley Cataracts 3 phaco machine. Sometimes in these cases I am able to hold at the center of the nucleus where it may be a little firm, but in this case this didn't happen. I could not hold it. I tried to slice, but it didn't happen. So what I try to do now is make a groove, try to divide and conquer. But after making some groove, thought I will try to hold the other side. Now I'm trying to prolapse on equator, holding it with vacuum, but I can't hold it and it is not prolapsing out of the capsular bag. So again I try to sculpt, go to phaco on mode, try to sculpt deep, and now I can see faint red glow, and now I try to divide the nucleus into two halves, but it doesn't happen. The fibers are leathery and sticky, and I could not divide the nucleus into two halves. Try to go farther deep at another place and try to divide here, but it is not giving in. So what I do is I come out, inject some visco, little bit of it, and now after injecting this visco I'm going to do hydro again, and I'll try to prolapse on equator out of the bag. Now here it goes. I'm doing hydro again, and as I do it I can see that the equator, which is between 9 o'clock and 5 o'clock, has prolapsed out. But this is not the right position of the nucleus so that I can emulsify it. So I rotate it because the main incision is there. It should be in alignment with the main incision. Now I will be able to approach the nuclear mass very easily. Now here it goes. I go again with the phaco handpiece and I try to eat off the equator, which is at this position from 2 o'clock to 7 o'clock, and I give a little support on the other side, the posterior surface of the cataract's lens with the chopper. But though vacuum was about 400, it was not enough. I increased the vacuum to about 500 and then I could remove some nuclear mass. Now you can see why it didn't crack. The fibers are very leathery and sticky. So soft cataracts can have very leathery and sticky fibers, and it is hard to crack. So soft cataracts may be hard to conquer in many situations. Now I inject some viscoelastic substance and clean the cortical matter. This part of the video is going to be edited. So after cleaning the cortical matter, I inject some viscoelastic substance, and in this case I have used HPMC, that is hydroxypropyl methyl cellulose. In this case I am going to use this lens, sensor multi-piece intraocular lens. Now dear colleagues, see what happens when you load the lens in the cartridge and when you place it on the injector. Sometimes you may see the trailing lobe on the groove of the injector. It should be with a Sinskey hook. Just bring it out and then you advance the lens towards the tip of the cartridge. Now here it goes. The main incision has been enlarged a bit and the lens is screwed in. I am taking care that the leading haptic is not hitting the posterior capsule. Now I injected a little bit of visco over the anterior surface of the lens. Now I place the trailing haptic in the capsular bag. Now a lot of visco is there inside. It was removed thoroughly using Simcoe cannula, irrigation probe or bimanual IA, and finally irrigation and aspiration. That's it. The pupil was dilated at the beginning of the surgery and now it is mid-dilated. Little bit of moxifloxacin is injected, the side ports are hydrated, and a final wash is given with pure BSS. This final wash is very important, I believe, to avoid TASS. Thank you very much for watching. Hope this video will be helpful in your practice.